Hi, it's Chris Flanagan. Welcome to the Paediatric Emergencies podcast. So we're back dealing with the paediatric critical care perils today, and I've got part 3 here for you today. Before I get into the paediatric critical care perils, I want to let you know about a new video that I posted up on the website, paediatricemergencies.com. So this is a comparison of 6 different video laryngoscopes in both adults and children. It's released only as a video and not as a podcast because it's mostly something to watch and there's not an awful lot of talking to do with it. So if you're anyway interested in intubation, video laryngoscopy, simulation, the video might be of interest to you. Right, we'll get on with the paediatric critical care perils. So starting with peril number 21. And peril number 21 is the best endotracheal tube is the one that's in the trachea. And what this peril really means is don't change a perfectly well placed oral endotracheal tube to nasal in an unstable child. And certainly in some departments, nasal tubes are routinely used. They're generally more comfortable for the children and there's less risk of unplanned extubation. So in general, the children are intubated orally and then the tube is changed over from oral to nasal. But prior to doing that, you have to weigh up the risks and benefits of the intervention, and the benefits of doing so have to weigh out any risks involved with the procedure. And the one patient where that isn't true is the potentially unstable child. So it's your septic patient, your patient who needs properly resuscitated. That's the child who you shouldn't immediately be changing an oral tube to a nasal tube. And there's a number of reasons for that. First and foremost, you're putting the child through an unnecessary intervention which has a high risk of things going wrong during it. You've got a tube in, the child's ventilating well. The only reason to change it, like I said, is patient comfort and security. However, the child's unstable, you're going to be keeping them pretty flat. The tube's going to be well secured. It's not likely to fall out at the moment. The tube can be changed at a later stage when the child is much more stable. So in that acute phase, the risks of changing the tube aren't outweighed by any benefits. And it's the last thing that child needs. They may be sick from a point of view of sepsis. Do you really need to add an airway and breathing problem to a C problem when you've already got it sorted out? The other thing is, while you're busy changing that tube, you're neglecting the circulation. There's lots of other things you could be doing to optimise that child, but you're doing an unnecessary intervention with the airway. And there's certain places, Northern Ireland certainly one of them, where almost a standard of care is a nasal tube in a critically ill child. And traditionally, it was encouraged that people in district general hospitals would try and put nasal tubes into these sick children. And when they were brought to the intensive care unit, it was almost a pat on the back you got. You brought this really sick kid, but still you've got a nasal tube in, well done. That's really changing now, and certainly if I'm going out to retrieve a child who's in septic shock or who's post-arrest, and I see they've got a nasal tube in, I'm almost looking to say, actually, I'm a little bit worried about your insight, that you thought this was the best thing to do in that potentially unstable child, was to put a nasal tube in, put them through an unnecessary intervention, when actually there's lots of other things that still need to be sorted out as well. Okay, to sum it up then, so the best endotracheal tube is the one in the trachea. Please don't put unstable children through unnecessary interventions by changing a perfectly good oral endotracheal tube for a nasal one, just because you think it needs to be done. Okay, moving on to peril number 22. So peril number 22 is remember the external jugular vein in difficult access, and don't forget about scalp veins and umbilical veins in neonates. So if you listen, a regular listen to the podcast, you know what my view on access is on hemodynamically unstable children. It's you spend maybe about a minute or so at most trying to get peripheral venous access. And if it's any way difficult, put an interosseous line in, get on with resuscitating the child, and you can sort the intravenous access out at a later stage. So at most I'm spending about a minute or so looking for a vein, and you want to make your attempts at venous access as optimal as possible. and the external jugular vein is probably your best bet in most children. It's easy to cannulate, and like I say, people are generally poking about at the peripheries in a shut down child where there's no veins, whereas if somebody puts an arm under the shoulders, extends the neck, there's normally a whopper of a vein that you can put a cannula into without much difficulty. But the problem is people don't think about it. So external jugular veins, you want the bed slightly head down. It's going to help fill the vein and prevent any air embolus. The quickest thing is just to get somebody to put an arm under the patient's shoulders. That will extend the neck, head over towards the opposite side. You want to then put a finger at the bottom of the vein to help distend it. Have somebody tense the skin on either side to fix the vein. And then the best way to actually, in small children, is to actually just transfix the vein. If you try to cannulate it directly, it's very difficult to cannulate just because of the angle. You almost always end up going through it. So my preferred approach is almost to intentionally go through it and catch it on the way back and out. Other options you have are scalp veins. Again, if you're somebody who deals mostly with adults, you won't think about scalp veins, but in neonates and small infants, they're often the best veins. They tend not to be the most secure, so if you get a cannula in the scalp, it's likely to maybe last you a day or so before it falls out. But that's going to be enough to get your child resuscitated, necessary blood samples taken, and then actually as they warm up and their perfusion comes back, you'll probably be able to get a cannula in somewhere else. So don't forget about the scalp. If I've got a sick neonate who's shut down coming in, they're the two places I'm looking for. It's the scalp or the external jugular vein are the two best. I do mention umbilical veins, something to think about. They're generally, for me, not a resuscitative line. You can probably do it in the first week of life, but as time goes on, it's harder and harder to get into the umbilicus. So if your child needs immediate access, intraosseous is probably better. But if you're looking for more secure access, remember the umbilical vein. You can put a normal central line or a feeding catheter into it and use that for your access. You don't need a dedicated umbilical venous line to go in. Like I said, it's a bit slower, it's a bit more awkward to do, so my preferred approach would definitely be the external jugular vein for access. Okay, so moving on to peril number 23. And peril number 23 is avoid the 3 H's in traumatic brain injury. So the 3 H's are hypoxia, hypercapnia and hypotension. And that just goes without say. Hypoxia and hypercapnia are potent stimulus to bring extra blood to the brain, and with that extra blood brings increased pressure in a child who's already got raised intracranial pressure. So they're really, really important to avoid the things that may cause secondary brain injury. And hypotension should be aggressively treated. Actually, in these situations of raised intracranial pressure and traumatic brain injury, you want actually supranormal blood pressure to try and push extra blood into the brain to maintain your cerebral perfusion pressure. So hypotension you need to get on top of fairly quickly. And like I say, your targets are going to be slightly higher than normal. If you want to find out more about that, there is a separate episode on raised intracranial pressure, which you can find in the podcast or on the website, paediatricemergencies.com. So avoid the 3 H's in traumatic brain injury: hypoxia, hypercapnia and hypotension. Okay, peril number 24. So peril number 24 is use lactate as a marker for occult sepsis. So the traditional teaching was that lactate was the product of anaerobic metabolism, and the thinking was that you weren't delivering enough oxygen to the tissues, so they switched from aerobic to anaerobic metabolism and you produce lactate. We now know that the relationship between of why lactate is raised in sepsis is a little bit more complicated than that, but in general an elevated lactate is a bad thing, and it tells you something's going wrong with your patient and you need to investigate it and treat your patient. You need to have a reason as to why the lactate's up. So with this in mind, you can use lactate as a screening test, telling you that there's something going wrong with your patient that you need to treat or investigate further. And the children who present with pyrexia, slightly impaired perfusion, it's a great test to do in these children to help you work out just how sick they are. I certainly can remember children who walked into the emergency department and then within maybe about half an hour or so develop a rash of meningococcal septicemia. You do their initial lactate as you bring them into the resuscitation area, and it's 8 or 10. Had that child have had a lactate done an hour ago, it probably was 6 or 7, and that would have flagged that child up as very sick. That would have been somebody you'd want to jump on to start resuscitation on. So maybe before they'd showed other signs of impaired perfusion, hypotension. So like I say, lactate's a great marker of occult sepsis before the patient decompensates, and allows you to bring important interventions to them at an earlier stage. Okay, so moving on to peril number 25. And peril number 25 is don't forget pH, steroids and calcium in shock refractory to vasoactive drugs. So these are all reasons why your vasoactive drugs may not work as you expect in an unwell patient. So most of your vasoactive drugs work by increasing intracellular calcium. So if your patient's calcium's in their boots, the drugs aren't going to work. So all these children should have a blood gas done and the ionized calcium checked on the blood gas. And if this is less than 1, you should give them some calcium. The other situations are where you're on multiple vasoactive drugs, your calcium is in the normal range, but you're still struggling in a vasoplegic child. In this situation, a calcium infusion has got me out of trouble on a number of times. So think about the calcium. If it's less than 1, certainly top it up and you'll find your drugs work better. And remember it, if for refractory shock, you might want to think about a calcium infusion when you're on multiple vasoactive agents and you've worked through the other steps that I'm going to tell you about now. A lot of these children have what's called relative adrenal insufficiency. So it's their adrenals are working overtime and they're producing lots of cortisol but just can't keep up with the demand. So generally when you've got shock resistant to fluid and vasoactive drugs, you should try and supplement them with some low dose steroids, and that's 1 milligram per kilogram of hydrocortisone 4 times a day, up to a maximum of 50 milligrams. And that's for relative adrenal insufficiency. High dose steroids trying to suppress the immune response have been shown to have a worse outcome and increased mortality and sepsis. So all you're trying to do is supplement what the adrenals would normally be doing. And the other situation where your vasoactive drugs may not work as you expect, if your patient has a particularly low pH, for example due to metabolic acidosis. So if you try and correct that pH through either bicarbonate administration or hemofiltration and improve it, the vasoactive drugs may work more reliably. The other reason why your vasoactive drugs may not be working, and it's important to consider, is have I got the right diagnosis? Is this really sepsis or is there something else going on? So if this is a neonate, the other things you need to think about, and you can see the Collapsed Neonate podcast that I mentioned, is this a cardiac baby? Do they have congenital heart disease or do they have an inherited metabolic disorder? Hemorrhage secondary to non-accidental injury is the other thing to always think about in these babies, and certainly neonates can lose enough blood into their head to make them hypotensive. So any shock neonate, the 4 things to think about are sepsis, congenital heart disease, an inherited metabolic disorder and non-accidental injury. So moving away from neonates, you do need an approach to any child who is hemodynamically unstable, and you need to have a differential diagnosis in your head as the things that can do it. So I do cover this in the sepsis talk, and the differential diagnosis is on the website paediatricemergencies.com. So I like to split this up into the mechanical causes, surgical causes, cardiac causes and others. So under the mechanical causes, these are things like a tension pneumothorax, a pericardial effusion causing tamponade, and abdominal compartment syndrome. The surgical things, anything nasty or on the tummy, can obviously cause hemodynamic instability, but in particular think about intussusception, volvulus, and bleeding. I've already mentioned congenital heart disease, but other things under the cardiac section are arrhythmia, myocarditis, myocardial infarction, particularly in babies who have anomalous insertion of the coronary arteries, and other things to think about. So think about toxins, diabetic ketoacidosis, pulmonary embolism, metabolic disorders, and anaphylaxis. So I do often, when I've got a child who's not behaving like they should, fix things like the pH, give them some steroids, optimize their calcium. And when you're still not winning, then you have to go through this differential diagnosis and go, am I missing something? So don't forget pH, steroids, and calcium in shock refractory to vasoactive drugs. And I suppose the additional thing to add here is make sure you've got the right diagnosis and consider the differential diagnosis. Okay, moving on to pearl number 26. And pearl number 26 is use adrenaline in life-threatening refractory asthma. So asthma was one of the first podcasts that I did when we talked about the routine treatment of asthma. There was a number of options you had when that wasn't working, and things you could add in for refractory asthma, and adrenaline was one of those. And I certainly used a low-dose adrenaline infusion to help get me out of trouble on a number of occasions. And the reason adrenaline's helpful in this situation is the beta effects cause bronchodilation, in addition to the other beta agonistic effects you're getting from the example salbutamol. But this isn't the main reason I've mentioned to use adrenaline in life-threatening refractory asthma. And when they looked at a lot of the asthma deaths, they realised that a lot of them were due to anaphylaxis that had been unrecognised. And as you know, the treatment for anaphylaxis is adrenaline or adrenaline or adrenaline. There's lots of other agents that are in the algorithm, but the main treatment is the adrenaline, and the other agents are mainly there to prevent recurrence of the anaphylaxis. So if you don't give these children adrenaline, they're not going to get better. So the main point of this pearl is to think, it's reconsidering the diagnosis, does my patient really have an exacerbation of their asthma, or could this be anaphylaxis? And either way, adrenaline's probably going to be helpful. So think about adrenaline in life-threatening refractory asthma and use it early in that setting. Okay, moving on to pearl number 27. So pearl number 27 is don't forget to send an ammonia in a collapsed neonate or any child with a reduced consciousness level of a known cause. And the reason I'm singling ammonia out, a metabolic problem, as we've mentioned, is always in the differential of a collapsed neonate or anybody who's got a reduced level of consciousness and you're not quite sure why. And there's a whole collection of tests that you're going to send off, and many of them will come back some days later, either confirming or refuting the diagnosis of a metabolic disorder. The reason I've singled out ammonia is it's time critical that you find out, does your child have an elevated ammonia, and it's time critical that you try and bring that ammonia level down through either one of a number of methods. The longer the child's brain is exposed to an elevated ammonia, and the higher the level of ammonia, the worse the outcome. So you need to know about it urgently. So any child who is at risk of having an elevated ammonia, you should send the test off urgently. Make an important point of looking for the result, chasing that result, because like I've said, it's a time critical diagnosis that needs urgent treatment if you're going to have a good neurological outcome. Okay, moving on to pearl number 28. So when giving drugs and fluids to critically ill children, remember you can always give more, but you can't take back what you've already given. So what do I mean by this one? When I'm talking about drugs, I'm mainly talking about the anaesthetic agents, your induction agents. And as we've mentioned previously in podcasts, unstable children tolerate anaesthesia badly. you should reduce the dose that you're going to give of your induction agent significantly, and even with those reduced doses, expect your child to have cardiovascular compromise on induction of anaesthesia. So for me, where I've got a relatively well child, the normal dose of ketamine I would give them to go off to sleep would be 2 milligrams per kilogram. A sick meningococcal is going to get 0.5 milligrams per kilogram at a time. So start off with 0.5 milligrams per kilogram, and obviously if they need more, they'll get it 0.5 milligram per kilogram aliquots, rather than starting with a higher dose that may cause more problems. When I come on to fluids, if you follow standard APLS guidelines, they say your fluid bolus in general is 20 mils per kilo as a push, although they do mention in certain circumstances such as diabetic ketoacidosis or trauma that bolus should be reduced to 10 mils per kilo at a time. So for me, in most circumstances, 20 mils per kilo at a time before reassessing the patient is too much. You may find that after maybe only a third of that fluid bolus, your hemodynamics are back to the way you want them to be. So why would you give the other 2/3 of that fluid bolus when your patient doesn't need them? So I much prefer to work in 5 or 10 mils per kilo of aliquots of fluid, providing I can stay there and continuously assess the patient as the bolus has been given and I'm not having to do another task. I suppose for me, the one circumstance where I would give 20 mils per kilo is your crashing meningococcal, who in that circumstance is significantly fluid depleted. You've often got other tasks that you're concentrating on, and it wouldn't be appropriate to delay fluid administration for frequent reassessment during those 20 mils per kilo aliquots. So, like I said, it's mainly fluids and induction agents that this applies to. So when giving drugs and fluids to critically ill children, remember you can always give more, but you can't take back what you've given. Okay, moving on to pearl number 29. Pearl number 29 is a simple one, but has very significant effects if you get it wrong. So it's aspirate the nasogastric tube continuously during face mask ventilation. As we've mentioned previously on podcasts, it's rare you do a classical RSI in children, and you will bag the child gently during the apnea period while you're waiting for the muscle relaxant to work before you can intubate the child. Your best intentions are that all the air that you bag in will go into the lungs, but a significant amount of it does go into the stomach. And that does two things. One, it increases your risk of aspiration. And the second is, as the abdomen distends, it splints the diaphragm and can impair your ventilation, particularly in small patients. So there is a simple way of avoiding it. You just have somebody continuously aspirate the nasogastric tube as you bag the patient. So what you do is you aspirate the nasogastric tube at the start, and that just clears any gastric juices that were present in the stomach. But what's important is you don't tick that job off and say it's done, because as you start manual ventilation of the patient, air will then start filling the stomach. So it is important that you allocate one member of the team to do that job continuously during face mask ventilation. Okay, moving on to pearl number 30. And pearl number 30 is don't believe the label the patient comes with or accept the current treatment plan without question. And this one's basically just what it says. So it's always make your own mind up about the patient and try not to be influenced by what the person before you has found. And we've already alluded to a little bit about this in the collapsed neonate or your hypotensive patient who's refractory to treatment. Have I got the right diagnosis? Or for example, your asthmatic patient, is this really anaphylaxis? So always query, have I got the right diagnosis, and make your own mind up about it. And this is particularly important at this time of year in bronchiolitis season, because every neonate that has wheeze or respiratory difficulties is labelled as bronchiolitis. And hidden among all those babies with bronchiolitis, there'll be the odd baby who has a congenital heart problem, maybe a congenital lung problem, a child with a metabolic problem causing them to breathe fast, or a baby with sepsis. So it's important you always consider the differential diagnosis and don't just accept the label the child has come with. The same thing happens with a treatment plan. Just because somebody else has made a treatment plan doesn't mean you have to follow it blindly if to you it doesn't make sense. So always query things, always make your own mind up about things. Okay, so that's another 10 paediatric critical care pearls for you. There's probably going to be at least one more part in this series, which I'll try and get out in the next few weeks. If you've been enjoying the podcast so far, I would encourage you to leave me a review on iTunes. And if you've got any questions or comments about this episode or any of the other episodes, please leave them in the comments section and I'll get back to you. Thanks for listening.